Welcome to this IAS-USA webinar. Today is Tuesday, June 14, 2022. My name is Jose Francisco, and I'm a project manager at IAS-USA. We're excited to cover today's presentation regarding the management and prevention of HIV infection among transgender adults. We're delighted to welcome Dr. Jill Blumenthal, Associate Professor of Medicine at the University of California, San Diego. We'll be going over our introduction slides and we'll be moderating the question and answer session at the end of this webinar. Welcome, Dr. Blumenthal.
Thanks so much, Jose. Good morning, good evening, good afternoon, somewhere in between all of those things. We're really excited to have you here so Dr. Asa Radix can talk to you about the management and prevention of HIV infection among transgender adults. Just a few housekeeping items. Just here are some of the financial relationships related to content on the web board. Here are the financial relationships with myself and Dr. Radix. Some CME information for you here. And on this slide about what has been approved. We get some grant support, or there's some grant support from commercial companies. The on-demand recording and slides will be available about 24 hours after this is completed. This is probably the most important slide. So there will be poll questions that will come up and you can choose your response from the poll, and the responses will be displayed after it closes. You can submit questions that we'll do in the Q&A chat box. There is also a chat, but that is meant to be with discussion with other attendees. And if you can try not to submit questions through chat, they're better through Q&A. And it is now my pleasure to introduce Dr. Asa Radix, who is the Senior Director of Research and Education at the Callan Lord Community Health Center and a Clinical Associate Professor of Medicine at New York University in New York City. In addition to being a board-certified infectious diseases physician, Dr. Radix has over 20 years of experience providing care to trans and gender diverse individuals. They have contributed to multiple national and international guidelines in transgender health and is currently the co-chair of the World Professional Association of Transgender Health Standards of Care version 8 working group. And with that, I will turn it over to Dr. Asa Radix. We're very excited to have you present.
Thank you so much for the introduction. And I'm just going to pull up my slides here. Hopefully they are working. Good. Are you able to see those? Terrific. Yes, thank you again. I'm really very pleased to be able to discuss some of the unique concerns that apply to trans and gender diverse adults who have HIV management or prevention needs. So I'm going to start with a polling question for everyone here. So how comfortable are you initiating a discussion regarding a patient's pronouns and gender identity? And you can see here it's 1, very comfortable, 2, somewhat comfortable, 3, somewhat uncomfortable, or 4, not comfortable at all. Oh, terrific. So it seems that that most folks are actually, either somewhat comfortable or very comfortable, and only a few are somewhat uncomfortable. So maybe we can talk a little bit about that when we get to the relevant slides. So the next polling question, I seem to be stuck. Let's see what's happening here. The second poll is, how would you rate your competence in prescribing gender-affirming hormone therapy? And the same options: very comfortable, somewhat uncomfortable, or not comfortable at all. Okay, good, because we will be covering hormone therapy in this presentation. So it seems that roughly just over half of the folks on the call are either somewhat uncomfortable or not comfortable at all. So yes, I'm very happy that you're here today. I'm gonna hopefully see if my slides will advance. So we just have a few learning objectives. So hopefully when we're done, you'll be able to discuss multi-level factors that impact HIV prevention and the treatment continuum for trans and gender diverse adults, describe best practices in hormone therapy management, and also just to identify some strategies on how you can create a welcoming practice for your trans clients. So I do need to go through the 2 pre-test questions, see where everyone, hopefully people will improve by the end. So this is a 56-year-old transgender woman who requests estrogen therapy. She is a 3-pack per day smoker. Her past medical history includes HIV, diabetes, and hyperlipidemia. Her medications include atorvastatin, metformin, bictegravir, emtricitabine, and TAF. So when considering beginning estrogen therapy, which will you do? Start the estrogen and spironolactone regardless of smoking status. 2, start transdermal estrogen and spironolactone along with partnership around smoking cessation. 3, do not begin hormone therapy until she has stopped smoking. Or 4, begin spironolactone only. Okay, so a little bit of spread. Most people answered number 2. And we'll go to the second pre-test question. Which statement is true regarding the use of PrEP in transgender people? 1, emtricitabine TAF is the preferred PrEP option for transgender men due to higher rates of chronic kidney disease. 2, CDC recommends on-demand PrEP 211 for use in transgender people. 3, transgender men should avoid emtricitabine TDF due to testosterone use. And 4, oral PrEP does not affect estradiol, estrone, or total or free testosterone levels in transgender individuals on hormones. Okay, good. So we'll be looking at these again at the end. So I wanted to kind of start this presentation with a short case. So this is a 38-year-old transgender woman who's newly diagnosed with HIV. And actually, this is based on a case report that was published in the literature, and you can see the reference. Her labs on diagnosis, she had a CD4 of 120, and HIV viral load was 500,000. She was initiated on dolutegravir and emtricitabine TDF, as well as trimethoprim sulfamethoxazole due to the low CD4. And 2 weeks after initiating ART, she developed fever and a rash, a gluteal rash, as well as inguinal adenopathy, as you can see here on the pictures. So just, thinking about maybe some of the things you might consider: secondary syphilis. We have actually seen some cases of monkeypox, cryoglobulinemia with leukocytoclastic vasculitis or virus. So just think about what might be going on here. And just to jump to the diagnosis, when they did the biopsy, they found that there was, as you can see here, a lipogranulomatous reaction on a non-birefringent oil-like substance. And it turned out that she had a past history of silicone injections into the buttocks. And actually, this was an inflammatory response that was triggered by agents such as silicones or oil-based fillers. And this, again, has been described in literature, and I thought it was a good case to start with. Really considering, like, why did I use this case about this phenomenon to begin a presentation about trans people? I think you should be aware that anywhere from 17 to 50% of transgender women have injected silicone into the buttocks, that the higher rates are seen more among Latina trans women. And again, I think all clinicians who are providing care to trans people really need to be really well aware of the medical and non-medical interventions that trans people may undertake. And that can include hormones, surgeries, and interventions like this, silicone, binding of the chest, tucking of the genitals, since all of these can have, very important effects on health outcomes. First, to start the discussion, I just wanted to make sure we were all on the same page and provide a few definitions. And we know, and I put it right here at the top, that, language around gender identity, is always evolving. And things that I say today, may be different in a year or two. The language differs across cultures and also geographically. But in this presentation, I'm really using the term transgender to describe anyone whose gender identity is different from their sex assigned at birth. And that includes folks who identify as transgender women, transgender men, other folks who are non-binary, gender diverse. So maybe having an identity, again, that's non-binary. Some people say, I hold both genders, and other people say, I describe myself as completely separate to male or female. And then, of course, cisgender individuals are those who are not transgender. We're often asked, how many trans people, kind of exist in the United States and worldwide, and we do have some data around that. It's estimated that around 25 million trans people live, globally. In the US, that's anywhere between actually we have new data in the last few days, 1 to 1.4 transgender people. And that's roughly about 0.6% of the population. I think it's also important to understand that the numbers often change when you look at the literature, depending on how we define trans people. So is it based on self-report, which is the 0.6%? Is it based on a diagnosis of gender dysphoria, which is going to obviously be a lower number because not everyone presents for medical care? Or is it on the basis of medical therapy? And as you'll see, many people never undertake either hormone therapy or surgical interventions. So it is really important for you as a provider to ask people about their gender identity as well as their sex assigned at birth. In the US trans survey, and this is a really large survey that's done every 5 to 6 years or so. The last one was done in 2015 and surveyed almost 28,000 individuals. 58% of trans people had experienced discrimination in the last year, and that included, sexual or physical attacks. The saddest part is about a third had experienced discrimination in healthcare. So because of that, almost a quarter are avoiding care. People face mistreatment at work. There are higher rates of unemployment, and people living in poverty than the rest of the US population. I put down here housing discrimination. You'll see why that's important when we talk about housing instability. Many people have been rejected from their families. And of course, we see very high rates of school bullying and leading to dropout. And all of these factors impact obviously on the, social determinants of health, and really are a key factor in why transgender people have such elevated rates of HIV and STIs. In the USA, when we look at HIV prevalence, in 2019, less than 0.4% of adults were living with HIV. And if we look at the numbers for, transgender individuals, the prevalence is much, much higher. You can see here among transgender women, a prevalence of about 14%. And this is much higher when you look at African-American trans women and Latina trans women. But transgender men, although we tend not to think of them as being at elevated, risk for HIV. The fact is, they are. I mean, you can see here 3.2%, although lower, is still much higher than the prevalence seen in the United States. And most of the transgender men do identify as, gay, bisexual, and otherwise men who have sex with men. One of the other facts is that you should be aware of, there have been a lot of data, a lot of studies that have been published showing that trans women living with HIV have less access to HIV care across the HIV care continuum. And this results in, for example, lower rates of retention in care, lower rates of use of antiretrovirals, lower adherence to ART, and as well as, lower rates of viral suppression. And we do have actually very recent data from the Brian White HIV/AIDS program. You can see here from 2020. I think the wonderful news was that overall, viral suppression has been is much higher across the board. So we're pretty close to 90%. And for transgender women, that's the last column. It's 84%, but again, this is the highest it's been across all the years that we've seen these reports. So, the gap is definitely narrowing. I do think it's important, though, to recognize that, there are still individuals who do have much lower viral suppression rates. So you can see here for African-American trans individuals, it's around 80% for those who are young. So either, 20 to 24 or 25 to 29. Again, you can see lower rates. And definitely if you're, someone who's young, as well as unstably housed, you're going to see much lower rates. So I have here in the last column, these are trans individuals who are African-American and experienced unstable housing. You can see here how very low the viral suppression rates are. So, these are all things to consider when you have a client in front of you, just finding a little bit about their life and obviously providing, assistance, whether it's housing assistance and other aspects to help folks achieve, optimal healthcare. So when we think about the factors related to viral suppression, there's been quite a lot of research done in this area. And one of the main, differences that comes up for trans individuals, especially transgender women, is that often they will prioritize transition-related care, so hormone-related care, over HIV care. And this is one of the reasons why it's really so important for HIV clinicians to be able to provide hormone therapy in the practice. Because, let's face it, if people have to choose between the hormone provider and the HIV provider, the hormone provider is probably always going to win. So, I think it's key to try and co-locate these services and for people to become more familiar with prescribing hormones to their clients. There are other things that we'll talk about, fears about drug interactions between hormones and ART. This is another issue that that women have raised, being worried that if they take ART, that somehow the hormones won't work. And then, of course, if you're prioritizing your gender care, it's one other reason to stop ART. So this is definitely a myth that we will talk about. Other issues, of course, negative experiences with providers and health systems, as we talked about before, fear of discrimination on the basis of gender identity, as well as, HIV stigma, the higher rates of mental health issues that often folks are dealing with, substance use, and again, we see unstable housing. So here I have another question for you. Providers caring for transgender women living with HIV on antiretroviral therapy should, 1, discontinue gender-affirming hormone treatment, 2, reduce the doses of estrogen therapy by 50%, 3, stop ART if they want to continue hormones, and 4, monitor hormone levels if an interaction with ART is likely. Good. So that seems that the majority of, actually 99% chose number 4, monitor hormone levels if an interaction with ART is likely. Okay, and that was the correct answer. So, you know, for a very long time, as I said, the clients that we worked with were often very concerned about the possibility of drug-drug interactions, and also providers. But it seems like most people here understand that this really isn't a very large concern. I think one of the reasons, of course, is because estrogen and testosterone are metabolized through the same pathways, such as CYP3A4, as some ARBs. That can sometimes cause serum hormone levels to increase or decrease. And I'm sure you've seen the new HHS ART guidelines actually have a section on special populations that includes trans individuals, and they include some tables that show possible directions of interactions that exist. But the takeaway message really is that in general, these interactions are not clinically significant. They do sometimes result in some small changes. And I've listed these here. You can see the 4 bullets. Most of the first-line regimens, such as the unboosted INSTIs, are not expected to change hormone levels, which is really what patients want to hear. Of course, there are some ART regimens that can decrease estradiol, such as the ritonavir-boosted protease inhibitors, and efavirenz and etravirine can do that. I also have some of ART that can increase gender-affirming hormone therapy levels. For example, cobicistat boosted elvitegravir, and protease inhibitors can increase testosterone and finasteride levels. And then there are some antiretrovirals that really have an unclear effect on gender-affirming hormone therapy. For example, elvitegravir and Cobi, and protease inhibitors with Cobi and their impact on estradiol. I mean, really, what we suggest that you do, and it's what the HHS guidelines suggest that you do, is if you have someone on a regimen and you're concerned about a possible interaction, that you can just measure the hormone levels and make a small adjustment. I mean, the fact is, though, that these changes are usually very minor, in the range of maybe 10 to 15%. And for the most part, the client shouldn't even notice a difference. But definitely, you don't want to see hormone levels that are too high. So in a situation like that, I would probably, reduce the dose of the hormones a very small amount. So again, the important takeaway is to monitor the hormone levels and adjust the hormone dosages as needed. There. We have another question. Transgender women at risk for HIV are less likely to receive PrEP than cisgender men. That's a fact. What are some of the reasons for this disparity? Is it worries about interactions with hormone therapy, mistrust of providers and researchers, low HIV risk perception, lack of trans-inclusive marketing, or all of the above? Okay, so it looks like most folks have chosen 5, which is all of the above. It's 96%, which actually is correct, and we will be discussing some of those in a little while. So what I wanted to do was first start with just a summary slide, like everything you need to know about PrEP in transgender populations. So they're all listed here, and then I'm going to go through on different slides each of these bullets. So first of all, PrEP uptake is suboptimal for transgender populations. That includes both transgender women and transgender men. We don't have data on non-binary folk, but I'm fairly sure if we did, it would show the same. There are also, besides low uptake, there's lower PrEP adherence and persistence. Again, there are no clinically significant drug-drug interactions between PrEP and hormones. For cabotegravir LA, you do need to be aware of silicone use, especially by transgender women, and fillers in the buttocks, because this, as you'll see, the studies did actually excluded people who had silicone in the buttocks. And also, when you're discussing options with clients, for transgender men and other folks who are trans who are assigned female at birth, you have, FTC TDF, oral and CAB-LA. And for transgender women, you also have the addition of FTC TAF. So we'll go through some of those. So, several studies have shown lower uptake of PrEP among transgender women, but the level of knowledge around PrEP is definitely increasing. I mean, I think the first study here is the study from 2015, that this was in San Francisco, where, less than 14% of transgender women had heard of PrEP. And they weren't very willing to take PrEP. And you can see the numbers have really changed, where we're seeing more and more people, especially in the last few years, have heard of PrEP. And definitely the rates of PrEP use are increasing. I'm involved in the last study, which is the LIGHT study. It's a LIGHT cohort across 6 different cities. We have over 1,200 transgender women enrolled. And you can see here that despite most of the women attending health centers that are LGBTQ friendly, recent PrEP use was actually extremely low. So only 13% were using an adherent to PrEP in the last month. And these are all folks who had indications for PrEP. We see the same thing among trans men, low PrEP uptake, and there have been a few studies that have shown this. And you can see here, this is a study from Sari Reisner in Boston. This was a survey of almost 900 transgender men who have sex with men. So again, identifying as most of them as gay or bisexual. Over half had indications for PrEP following the CDC guidelines. Many had heard of PrEP, but only a third had reported any lifetime use of PrEP, and only 1 in 5 were currently taking PrEP. So again, this is really quite startling, especially when we consider that transgender men who have sex with men have about 11 times the risk of acquiring HIV compared to transgender men who don't. So, definitely indications for PrEP here. The other thing I want you to bring up was PrEP persistence. And when we talk about PrEP persistence, we're talking about PrEP use over time. In many studies, we've seen that PrEP use has been shown to be quite short, with most people using PrEP stopping within 6 to 12 months. And that's everybody. And I'm sure you've experienced this yourself with your clients. Now, there are a few data for PrEP persistence for trans people, but I did find 2 papers. The first was from a PrEP demonstration project, and that was called PrEP for PrEP. That was actually in Vietnam. And in this study, it was interesting. About half of both cis men and transgender women stopped PrEP by month 18. You can see that on the slide. But we do have a US study, which was in San Francisco, and this looked at PrEP discontinuation rates within the, so I'm just going to go back here, within the San Francisco Department of Public Health primary care clinics. And they found here that transgender women were twice as likely to stop PrEP as cisgender men. So I think that was an important paper. Again, many studies looking at why transgender women stop PrEP. I mean, they stop for many of the same reasons that everyone stops PrEP. Sometimes it's cost, sometimes it's lack of competent and knowledgeable providers. I mean, there are PrEP stigma. There are other things too that are really the same as why people don't take ART for HIV treatment. Prioritization of hormones and gender care, worries about hormone interactions, medical mistrust, right? So these are again, all factors that can impact on care. So, again, there are some facilitators to PrEP, trans-competent services. So again, providing gender-affirming care alongside PrEP, prescribing hormones at the clinic, having materials and health promotion. This is one brochure here from New York City showing that, trans individuals who are using PrEP. And then the last is that it's recommended by a medical provider. And there's still many people who say, my provider never spoke to me about PrEP. So, and this is something that you can do. When we talked about, question of drug-drug interactions, a few years ago, there was a lot of interest in whether hormone therapy, specifically estrogen, could reduce, tenofovir levels. And what I wanted to do is to show this study, which is the most recent study that looks at PrEP in trans people, both those on estrogen as well as those on testosterone. And it really is the only study that's included transgender men to answer this question. So they took 24 trans men on testosterone and 24 transgender women on estrogen. They were given oral PrEP with FTC TDF and followed for 4 weeks. And the main findings from this study, and I'll put it here, that serum hormone concentrations were not impacted by FTC TDF PrEP use. This is what your patients are going to want to hear. So, you can show this study, quote this study. I think it's super important. Specifically, and this was the answer to the question, oral PrEP did not change estrone, estradiol, total or free testosterone, dihydrotestosterone, or sex hormone binding globulin. The other part that was, I think, really important was when they compared levels of PrEP in cisgender men, transgender men, and transgender women. They had comparable drug concentrations in dry blood spot after 4 weeks of directly observed treatment. So I think, again, this is really important. All of the participants were projected to achieve highly protective concentration. So I'm hoping that this really answers the question about, oral PrEP and hormones that your clients might have. This slide is looking at cabotegravir PrEP. As you probably are aware, cabotegravir was approved for PrEP after we saw the results from the HPTN 083 and HPTN 084. Now, 083 included, cisgender MSM and transgender women. It was multi-site. But as I said before, those who had silicone implants and fillers were excluded. And I think that is important for you to consider as you're thinking about rolling out long-acting cabotegravir for PrEP. And again, there was a 66% reduction in incidence with cabotegravir. And the second study, the HPTN 084, was in cisgender women, really finding, again, high efficacy. So, it's all good to have these options, but what do trans people really think of PrEP and some of the future PrEP options that are still being studied? Transgender men are very interested in injectables, and many of them are already using injectable testosterone. So, the highest proportion actually were interested in injectable, long-acting injectable PrEP. 22% were interested in oral PrEP, and a smaller number in anal gel. And transgender women, again, interested in long-acting injectables and implants, but there were concerns about scarring, hormone interactions, and the number of provider visits that might be needed. And this, actually, I just put in some quotes from a study from a researcher at Columbia that basically said, I like injections a lot because an injection is liquid. It's just a quick pain. You don't have to worry if you're taking your pill every day. But again, community concerns have arisen over the fact that so many women have used injectable silicone, and they might be excluded, well, probably will be excluded from this option. So again, just to look at the summary sheet, as I said, PrEP uptake is suboptimal. There's lower adherence and persistence. You don't need to worry about significant drug-drug interactions between PrEP and hormones. We already talked about cabotegravir LA, being aware of silicone and buttock fillers. And again, the options that are available for transgender men and transgender women. Now, the reason why FTC TAF is not here for transgender men is because it was never studied in people who have vaginal receptive sex. So that's not listed as an option here. So here we have another ARS question. Data show improved healthcare outcomes, including HIV care engagement when hormones are prescribed. What barriers prevent medical providers from prescribing gender-affirming hormone therapy? We have lack of training. Providers consider hormone therapy outside their scope of practice, concerns about liability, religious objections, or all of the above. This is a short one. Okay, looks like most folks picked 92%, all of the above. And sorry, my slide stuck again. And that was correct. This is a survey that was done, and actually it's very recent, 2022. This is a survey of HIV practitioners, so 385. 57% prescribed gender-affirming hormone therapy, but of course that means that over 30% didn't. The barriers were, as you pointed out, lack of training for a third, that many weren't seeing transgender clients in their practice who were living with HIV. Lack of available qualified mental health professionals was on there. The belief that hormone therapy was outside their scope of practice in about 10%. And fewer numbers, but concerns about liability, and of course there were some personal and religious objections. And I thought this was a really important paper to really guide what we should be doing, which is hopefully training people to provide this care. So this is a 45-year-old transgender woman who requests hormone therapy. Past medical history includes HIV, hypertension, and hyperlipidemia. She's on atorvastatin, lisinopril, dolutegravir, and procitabine, and TAF. So how, just a few questions for you to be thinking about. How are you going to assess her for hormone therapy? What is the dosing you should consider? What changes would you expect to see on estrogen? And what additional aspects of care should you be thinking about? So I wanted just to talk about the general approach to hormone management for those of you, maybe the 30-odd% who are not providing this. This slide shows everything that you need to know. All you're doing with hormone therapy is recreating the hormone environment that's aligned with someone's gender identity and their goals. That's all you're doing. You're going to start with lower doses of hormones, which will either be estrogens and androgen blockers for transgender women and testosterone for transgender men. And I should say, when I say, transgender women and transgender men, non-binary people who are assigned male at birth or assigned female at birth may also want hormones. You titrate the doses as tolerated, and there is a maximum dose, so you're not going to exceed that. You then monitor the hormones in response to treatment, and you maintain the sex steroids within the usual physiologic range. I mean, that's really it. It's like everything you need to know. There are some criteria, obviously, for to initiate gender-affirming hormone therapy. And it is possible to do this without a mental health provider. So, if someone, the first is persistent, well-documented gender dysphoria or gender incongruence. So if someone can tell you their story, and you can absolutely initiate. You do not need to have a mental health provider. You should be able to determine they can consent to make a fully informed decision, consent to treatment. That's really important. The age of majority in a given country. That we do have guidelines for folks who are younger, but I would suggest that, think about referring those legal minors to, gender clinics that specialize in that. And then if someone has a mental health concern, it should be reasonably well controlled. So if someone is, I'll say if someone is depressed because of gender dysphoria, that usually resolves once they can access hormones, if that's what they're asking for. But, as long as someone has the capacity to make an informed decision, you can initiate hormones. So what do you do on the initial visit? So, we talk about patient goals. Usually I'll get a health history. I'll do a physical exam if the person is willing. If it's not done that visit, you can do it at a later time. Sometimes it does take a little bit of a few visits to establish trust and rapport. We do relevant laboratory tests. Obviously I want to, the most important thing really is the past health history. We discuss reproductive options. If you take gender-affirming hormone therapy, you will be less fertile. It's really important to have that discussion. Talk about the expected effects of hormone therapy and possible adverse health outcomes. In our clinic, we have people sign a document, but you don't need to do that if you're documenting clearly. And then we talk about the medical monitoring. So generally, we'll see people after a month, and then quarterly for the first year, and then after that, once or twice a year. If someone's living with HIV, you're seeing them fairly frequently anyway. So again, you can do this all at the same time. Before you start, though, you want to consider any health conditions that could be made worse due to hormone therapy. And if that happens, if you don't have a lot of expertise, you probably should be co-managing with someone who has more expertise in this area. So does someone have a history of thromboembolic disease? Is there a hormone-sensitive cancer? Do they have cardiovascular disease, severe hypertension? Is there unstable liver disease? Again, these aren't necessarily contraindications, but you should maybe discuss with someone else who has more information. Does someone have renal insufficiency or hyperkalemia? Because we use spironolactone as one of the androgen blockers. So again, these are all things that you should consider. For transgender women, we do an estrogen again, so you can use oral, injectable, or transdermal estrogen. Again, you start at the lowest dose and titrate, and monitor levels. So, if someone comes in, I'll start with 1 milligram of oral estradiol a day, or a milligram twice a day, and then I will go up to higher doses. So the androgen blockers, as you can see, we use mainly spironolactone. You can also use other agents like finasteride, not as effective. And cyproterone acetate, your clients might get it from Mexico or from Canada. So it's just to be aware that that's also used. So what do you expect to see? On feminizing therapy, you'll see breast growth, you'll see softening of the skin, changes in fat distribution, decreased muscle mass, usually in the upper extremities. We talked about fertility, so decreased sperm, reduced fertility, and reduced testicular volume. Some changes are permanent. Some changes are reversible, and other changes we're not so sure. Breast growth, if you develop breasts, that's permanent, right, for transgender women. We're not sure, as I said, about some of the things, for example, fertility, but these are all items that you should discuss with people. There are some medical risks, and these include thromboembolic disease, so much higher rates of, deep vein thromboses and PEs, just as you would see with, a cisgender woman, for example, who is a smoker, who is using oral contraceptives, right? So these are things that you need to discuss with folks. There's possibly an increased risk in breast cancer. We've seen from Europe, from the Netherlands, much higher rate of breast cancer in transgender women compared to cisgender men. There's also high rates of coronary artery disease, cerebrovascular disease, high triglycerides. So these are all things, again, that you're going to be monitoring and taking care of any modifiable risk factors that someone might have. If they smoke, discuss smoking cessation. If they have hyperlipidemia, obviously addressing that as well, like you're already doing with your clients. This is a second case. This is a 34-year-old non-binary patient who's assigned female at birth, who comes in for a routine checkup. They've been out of care for many years, wants to start testosterone, and they've had top surgery. This person used testosterone for 2 months at age 25, didn't have any adverse effects. And the other important thing to see here is that they have a cisgender male partner and they use condoms. So again, like thinking about the types of questions that you might have, how are you going to assess this individual for hormone therapy, and what is the appropriate dosing? I put in a question here: is testosterone therapy different for non-binary people? I mean, it's not. We just kind of follow what people's goals are. What other aspects of care are you interested in, and what changes are you going to see on testosterone? And I think the same thing again, you have to consider any conditions that could be made worse, with hormones. So if someone has a hormone sensitive cancer like breast cancer, definitely this is a situation where I would manage the patient with the oncologist and the breast surgeon. So you don't have to have all the answers as long as you have a good network of people who you're working with. Uncontrolled coronary artery disease or unstable, heart disease or hypertension with end organ damage. And active pregnancy is the one item that is an absolute contraindication to using testosterone. So again, that's something to talk to clients about. Many of you have been using testosterone for hypogonadal cisgender men. So you can see here the dosing is pretty much the same. We start off with a lowish dose and titrate up. Most people are going to be using either transdermal testosterone gel or testosterone cypionate, either every week sub-Q or every 2 weeks IM. And again, you titrate up and please don't exceed the upper limits. You will see definite changes. I mean, these, again, happen over time. And I should have said for transgender women, most of the changes take 2 or 3 years, so it's not going to be overnight. For transgender men, really the same thing. You may start seeing changes in facial hair in the first few months, but most people aren't going to have an effect for a few years. You also see, again, change in fat distribution. The voice will deepen. You'll see increased muscle mass. You can get androgenetic hair loss or male pattern baldness. The periods will stop, and there's also enlargement of the clitoris. If you look here, you'll see that some of the changes are permanent, far more for transgender men. So if their voices got deep, or they've got facial hair, beard hair, those things are permanent. If they experience scalp, hair loss, that's going to be permanent. And enlargement of the clitoris is also permanent. But other things, for example, if they stop testosterone, the menses will return. So again, these are all things that you should be talking to your clients about. Sometimes I hear, people will say, "Oh, I don't like my beard hair. If I stop testosterone, will it go away?" And it's like, no, it's permanent. You'll have to find another way of removing facial hair. Some of the things we see on testosterone, an increase in the red cell count. So, and the hematocrit can be quite high. We don't know what the outcomes are. We often tell people to donate blood. I haven't ever seen severe liver dysfunction, but it's in the textbooks. Again, slightly higher rates of cerebrovascular disease. We're not sure about breast or uterine cancer. It's really a bit of an unknown. So I should say that's a possible, and hypertension is also a possible. As far as laboratory monitoring, again, it really depends on so many factors, right? Does the person have coexisting medical issues? how old are they? But in general, we do try and evaluate people at least every 3 months in the first year, and then 1 to 2 times per year after that. I usually see people a month after starting hormones as well. You're going to be measuring hormone levels, prolactin levels. That's some of the guidelines say you should be monitoring prolactin levels annually. Other guidelines say it's unnecessary because prolactinomas are so rare. So I would just say follow the guideline that you like to use. Transgender women, in general, lower testosterone levels are the goal. But again, you should talk to clients about that. But the serum estradiol level should not be too high. So you want to keep it below 200. For transgender men, the target level of testosterone is anywhere between 400 and 700. And I just gave some guidelines here. If you're using intramuscular, you should measure it mid-cycle. If the person is using transdermal gel, draw blood about 2 hours after application. When people initiate hormones and they're coming in to see you, a few things that we do, how are things going? Are you having, assess their comfort with transition, find out about their social supports. Sometimes, for example, partners who are very supportive may not be supportive when they start seeing the changes, physical changes happening. As a provider, you can assist people with legal name change, changing gender markers and so forth. And this is always a good time to, just monitor mood cycles and family issues. So really anything that comes up during those visits, it's not just about checking laboratory results. I put this slide here because I thought it was, a good guide to what you do when you have laboratory results that are often accompanied by a range that's by sex, right? So it'll be like a female range and a male range, right? For the most part, once someone has been on hormones for about 6 months, you should, when you're looking at the hormone levels, you should use the affirmed gender or how someone identifies for most labs. So that would include hormones, creatinine, estimated GFR, hemoglobin, hematocrit. So all of these. There are only a few instances where you should be looking at sex assigned at birth. So that would be PSA for transgender women, although the PSA actually will be lower, cardiac troponin, and alkaline phosphatase. So I put those there. Other things that are interesting, I think, just to remember, if you're sending someone for spirometry, you should be using their sex assigned at birth, not their gender identity, because most adults, their chest size is where it is when they're seeing you. They're not growing that much more. And mistakes can happen if you don't do that. For renal function, again, it's important that you're using affirmed gender, when you're looking at this, because when you start testosterone, your serum creatinine will increase. And, you just need to be aware of that. When you're on estrogen and androgen blockers, the serum creatinine is going to decrease and it's going to overestimate the GFR. So always consider where someone is, how long they've been on hormones. And you also have the option of doing a measured creatinine clearance or using cystatin C-based GFR. So, we talked a lot about people being staying away from care because they felt unwelcome. Sites weren't friendly, sites weren't welcoming, and all the things that happen to keep people out of care. And then there are just a few things that you can do in your clinic. And I would just suggest, walk into your clinic and just think about all the systems that exist and what you can change to make things better for clients. Or if you have, you can ask if you have, transgender staff members, or you have, a patient who's trans, just say, is there anything in the clinic that made you uncomfortable when you came in? Often this occurs even before someone comes into the clinic. They call up on the phone and someone is using, immediately says, sir, because someone has a deep voice, and, that's incorrect. You shouldn't be doing that. So, just think about all the aspects that you can change, including having intake forms that allow people to write their gender as well as sex assigned at birth. Your staff should be reminded that they should use people's chosen names and pronouns. We're all here learning, so knowledgeable providers as well. And also just about the images and brochures and things that you have, just look through them to ensure that they're not going to be problematic for trans clients. I also put gender neutral and inclusive bathrooms and trans identified staff. One of the things that happens, people check in. And the first question is you have to, check a box, right? Male or female. So this is what we use in our clinic. We actually have a range of gender identities, and we also ask sex assigned at birth because that's really necessary for things like cancer screening and other issues. We make sure that we have a lot of brochures and things like that available. Also, we talked about physical examinations and think about the language that you're using. This is actually advice for if you have a transmasculine patient, transgender man, using terms that are less gendered. So instead of talking about his breasts, you can talk about his chest. Instead of talking about, different parts of his body, you can try and use less gendered language. Now I'm saying that, but some people are actually okay with you using gendered terms. So I think it's just important to check in with folks about that. So just for a summary, transgender individuals, as we pointed out, have many health disparities, including HIV. There's definitely a need for increased PrEP awareness and use. Gender-affirming hormones are associated with improved utilization of healthcare, which is, I think, really important, and the reason why we co-locate services, as I said. And we discussed many things, but definitely clinical competency, providing hormones and having a welcoming environment are really important to improving engagement in care. And that's both for use of PrEP and ART for treatment. And then I spoke a little bit about, sex at birth and gender identity and how that impacts. So always consider, right, how that's going to impact laboratory markers and health outcomes. And I know there were a few questions that have come up already about cardiovascular risk, and we can talk about that. So I'm just going to go through the post-test questions, although you did very well on the pre-test questions. So this is, again, the 56-year-old transgender woman who is requesting estrogen therapy. She's a smoker, living with HIV. She has diabetes and hyperlipidemia. On atorvastatin, metformin, bictegravir, and precitabine and TAF. When considering estrogen therapy, you should, 1, start estrogen and spironolactone, regardless of smoking status. 2, start transdermal estrogen and spironolactone along with partnership around smoking cessation. 3, do not begin hormone therapy until the patient has stopped smoking. And 4, begin spironolactone only. Excellent. 89%. So just here, and I realized that we didn't talk that much about choice. Transdermal estrogens are always preferred for folks who have significant cardiovascular risk factors. I think that might have been one of the slides that I cut out for time, but all the guidelines, the UCSF Center of Excellence, as well as the new WPATH guidelines coming out, spend a lot of time discussing the evidence behind using transdermal estrogens for folks who have significant risk factors, especially those who are over age 50 and who are smokers. So let's go on to question number 2. Which statement is true regarding the use of PrEP in transgender people? Emtricitabine TAF is the preferred PrEP option for transgender men due to higher rates of chronic kidney disease. 2, CDC recommends on-demand PrEP 211 for use in transgender people. Transgender men should avoid emtricitabine TDF due to testosterone use. And 4, oral PrEP does not affect estradiol, estrone, or total or free testosterone levels in transgender individuals using hormones. Okay, all right. The correct answer was 4, oral PrEP does not affect hormone levels in transgender individuals using hormones. I just want to just go back through here since we're on this. So, you know, it's emtricitabine TAF, remember we had discussed, was never studied in people who have receptive vaginal sex, so it would not be an option for transgender men. Now, CDC has included in the most recent guidelines on-demand PrEP 211 for use in cisgender men, but not for folks with trans experience. Transgender men, yes, emtricitabine TDF is the oral PrEP for transgender men. So that answer is incorrect. So the correct answer was 4. Good. So I'm going to just stop sharing my screen because I know we had a number of questions that had come up.
That was incredible, Dr. Radix. Lots of questions came through. I'm trying to organize them for you. I think just related to what you just spoke about, related to PrEP. One of the questions was, is there any contraindication to 211 oral PrEP, which I guess is a little bit different than should people do that? So how do you answer that for patients who say, I really want to use 211, who are trans?
Yeah. So, and that's a great question. I mean, we're using 211 off label anyway. The fact that we don't have a study in, transgender individuals, I mean, I would offer it as an option if, especially if you have someone who cannot take, daily oral PrEP and, and injectable, long-acting CAB is not an option for them. Yes, I mean, this is a situation where I think you need to offer an option, even if it's not the preferred option. And it's not the preferred option because of lack of data. So it's an easy answer. And I know in like in California, I know that folks have been using this for a while. We just don't have data on outcomes.
Thanks. This is coming off of the question related to, are you talking about transdermal estrogen? Janice Huber asked, some patients prefer injected estrogen. How much safer is transdermal? And is that an option for people in similar situations with, the higher risk of cardiovascular disease?
Yeah, I mean, I think the important thing is that it hasn't been studied, but, for the clients who we care for, in general, I will suggest transdermal also because the levels are nice and they're easy to monitor. We don't have those like super physiologic levels and the subtherapeutic levels for folks. So I will explain, I do have conversations about why, a steady dose is probably better. I mean, there are studies coming out of Europe showing, that you're seeing things like increased CRP when people have these super physiologic levels. And I don't know what that means. So I just say, I prefer transdermal, but yes, I'll use injectable probably before using oral in a situation like that. So that's kind of a non-answer, but I think it's just a data gap. So an area where we need to do more research.
I think this leads really well into the next question. So when a patient is on estradiol, what do you do about a very high estrogen level, or what about a very low estrogen level? How do you manage that?
Yeah. So with the low level, I think it really depends on, is the person happy? You know, if the person is happy with the changes, you know, there's a wide variation in cisgender populations for hormones. So just because maybe it falls on a little bit of the low side, I don't see that as a problem. On the other hand, elevated estradiol levels, you know, we actually know that it's not going to aid in feminization, right? So there was an interesting study that was actually done as part of the ANIGI cohort, which is actually a multi-site cohort in Europe that includes like the Netherlands and Belgium, I think Italy. I don't remember the other two countries, but they were able to show that the level of estradiol actually didn't correlate with the changes that you see. And I think it's just a matter of explaining that to clients, and also saying that these really super elevated levels are, don't improve effectiveness and have a downside, right? So, but as we get more information, we're able to actually talk about this knowledgeably.
No, it's so many knowledge gaps, but it's wonderful that so many things are starting to be answered over time. So I think another thing that comes up frequently for providers, what happens when a patient wants to escalate their hormone therapy when they're seeing results that they don't feel are acceptable? How do you handle that?
Yeah, so often what we see is, and this is usually for trans feminine folk, are often, bring up, the breast growth and things like that. And what I say is, this is just like puberty. You're not going to see changes overnight. So, you need to give this time. And as you saw from the table, it can be anywhere from 2 to 3 years before you plateau as far as breast growth. If you look at cisgender women, there's a huge variation in the amount of breast growth that you see. Some folks have not a lot of breast tissue, and some people have a lot of breast tissue, and some of it's genetics, and it has nothing to do with the dose of the hormones. If someone is not happy with where they are, maybe this is the option is to discuss surgery, like implants, because escalating the doses of hormones is not going to make a change. And if you think about it, the hormones for transgender women, it really is the breast growth. Yes, you get the fat changes and the hip changes, but often the breast growth is what women want to see. So and luckily we do have a surgical intervention for that. Much better to do that than to be using other agents or using very high doses of estrogen, which again, we know from a recently published study is just not effective.
Well, I don't want to leave oral estrogen out, and there is a question about that. So can you talk about the medical preference of oral versus injectable estrogen? Is there faster onset of action or differences in ultimate physical changes with injectable versus oral? There does seem to be some myths out there, some things perpetuated over time.
So and it's a great question. Unfortunately, we only have a study that looks at oral versus transdermal and actually found equivalent changes. We don't have anything for injectable. So that's a question I can't answer, but I can say that the US is one of the only, maybe the only kind of country in North America, Europe, that uses injectable estrogen in, as I said, across Europe and in the UK and in Canada, they use oral, and women are very pleased with the changes that they see. So, and that's where most of the research is coming from at this stage. So, I just showed the data from those countries.
That's really helpful. Okay, I'm going to move a little bit into surgery. There were a few questions about that. So what are your thoughts about the continued need of transgender people to see psychiatrists before gender affirming surgeries? Sort of, I guess, the before and after. How long do you think it's appropriate or necessary?
Yeah, right. So with the current standards of care, which you have to realize were written over 10 years ago, it was a model where people would see a mental health provider who would give, actually two mental health providers who would give letters before getting genital surgery. I can't say too much about it, but, over the years, we have found that, maybe that wasn't absolutely necessary, that assessments can be done by other individuals who have greater knowledge of the client than a kind of one-off, I need a letter appointment. The new standards of care are coming out next month. And I would say this is an area that has changed. I mean, I can talk about the draft guidelines that were published in December, did not have a mandatory mental health assessment and only required one assessment. And this is for adults. I should say this is for adults. So it's a great question, and the question will be answered in about a month's time. So
keep everyone one meeting and one more.
Yeah.
Another question related to surgery. Do you follow or do you check PSA in transgender women who've undergone gender affirming bottom surgeries?
Right. And it's a really good question, but also women who are receiving estrogen and androgen blockers beforehand, right? So what we found is, well, first of all, I'm sure most people know this, but when you have a vaginoplasty, which is using tissue to create a vagina, so either using penile and scrotal skin or using an intestinal graft to create a vagina, the prostate is left in place. So you will see case reports of transgender women who've had prostate cancer, and sometimes very aggressive prostate cancer. So, but it is less common, and it's probably less common because they've been on androgen blockers usually for quite some time. You can measure a PSA, but the PSA will be much, much lower. So just because a PSA, if you happen to be doing it, usually the upper limit, some experts say should be 1, and other experts say you should either triple or quadruple the PSA in order to kind of decide what is the kind of actual level. We don't have a lot of good information on that. I mean, PSAs, some surgeons will ask for them to be done before surgery, but as you know, when you do a PSA, it really is a conversation that you have with your client about the benefit and the risks of doing a PSA. So that's going to be different for every person in front of you.
Yeah. We have a research question. What would you recommend for clinical researchers setting transgender inclusive laboratory reference ranges for eligibility criteria? Is it the same as the clinical care table that you showed?
Yeah, I mean, I think first you have to determine, is the person on hormones or not? Because, if the person is not on hormones, then you should be using assigned sex at birth, most likely. If the person is on hormones, have they been on hormones for 6 months or more? And it also depends on what you're measuring. We don't know for some lab measures what we should be using. So it's, I think this is an area that definitely needs more investigation.
Okay, thank you. There are a few questions sort of, I think, that are a little bit related to what would you recommend for trans feminine people who don't want breast growth, but want everything else, or want one thing and not the other thing?
Yeah.
What do you tell them?
You know, hormones will work differently in everyone, right? So there's no guarantee that, you know, that you can take, like, for example, I've had transgender men say, you know, I want to be on testosterone. I want my voice to get deep, but I don't want facial hair. And we have to have the conversation that you can't really predict the changes that you will have. Some of it's genetics, some of it's about dosing, some of it's about the time you're on these hormones. So, you know, unfortunately, we just don't have a good way. Some folks have discussed using agents like SERMs, but we have no data. So I always say to people, expect that you're going to see all the changes. And, you know, and that's one of the reasons also why perhaps you might want to start off with lower doses and just see how you're doing, because you can always back off on a dose, you know, if you decide to later on. It's an excellent question, though. This is something that we grapple with all the time.
Yeah, and I frequently will talk about genetics or say, you know, what do you see in your family? Because that's what you might expect. So here's another question about missing appointments, because I think this comes up a lot. You know, what's our role as gatekeeper or you know, harm reductionist? So what do you do when patients miss their follow-up appointments? Are enough refills given to get patients to the next appointment? Do you do more than that?
I mean, is this for hormones or for PrEP or?
Yeah, it's a great question. You know what? It looks like it could have been for either. Let's say it's for both or either.
Yeah. Well, I mean, I think we've all seen as providers who prescribe PrEP, you know, I mean, the most harmful thing that you can do is to stop someone's PrEP, I think, you know. It's just, if you take it all the time and if you're adherent to your PrEP, you know, the chances of, you know, seroconversion are low, but if you stop someone's PrEP until they can come in, that's actually when we see people acquiring HIV. So, you know, I always try and, you know, give folks enough PrEP to, you know, until they can come in and get their labs done. If it's a young, healthy person, you know, without a history of kidney issues, I mean, they've even pushed for young people, you know, like kidney tests once a year. I mean, you know, I mean, for PrEP. So, but we do want to get HIV screens. For hormones, you know, if you're worried about someone's potassium, you could always give them estrogen and stop the spiral. I mean, the estrogen on its own is fairly safe. So, I mean, I think it really depends on I mean, I'd probably have, if I had 100 people, I'd have 100 different decisions about what I would do, right? Yeah, but so no rules about, you know, stopping, but I can understand why it can be challenging if you've had someone who's been missing appointments, and we're now into the second year of, you know, of not coming in for a hormone appointment. You know, I mean, I think we all have to have a point where we say, well, not until you come in. So.
And this is how we need and try to be patient-centered and realize that there are a lot of barriers to care, and maybe in all your time you could explore what those barriers might be for patients, but that's obviously a big consideration. It is 11:19. There's still a couple more questions. I think they're quick. Do you still have time?
Sure. Yes, I do.
So. Okay. There was a question about 211 for transgender men. So I think that was an intention about, you know, would you ever offer 211 to a transgender man?
Yeah, I mean, I have to say I haven't, but I know people who have. I think that we definitely need more data. I mean, I think it's a little bit different for, I mean, we know, for example, that for when you're taking oral PrEP, that you need to be on oral PrEP for a little bit longer to achieve the appropriate levels, like in vaginal tissue. I myself would be a little concerned about that. I don't know how you would feel. I would feel myself a little bit concerned. I mean, I wouldn't have you know, for transgender women, you know, I think most people have offered 2-on-1 for transgender men. It's just not been something that I've been able to do.
Yeah. I mean, I think the only time where it would feel safe and appropriate would be if they said they were only engaging in anal receptive sex. But I think they just have to, it's just this is what the data shows. This is what the data has not shown yet, or we don't have information on. So yeah, I have yet to do it either. And it really hasn't come up in that way for me, at least. How long should a trans woman be taking estrogen before going for implants?
Oh, that's an excellent question. There is no minimum time period, but I think most providers and surgeons will explain that, because breast growth is happening over a period of years, when you choose your implant size, the problem is that you may have further breast growth due to estrogen. So, if you're going to be on estrogen, it's usually worthwhile waiting a little bit of time. At a minimum, it should be 6 months. But I think most surgeons would encourage people to stay on hormones a little bit longer, just so that they're not unhappy with the end result, because you just don't know if the breast growth is going to be symmetrical, asymmetrical, is there going to be more or less? And then you might have to go in for a revision. It's already hard enough to get insurance companies to pay for this. So,
And what makes this so challenging too is that a lot of surgeons will tell you, when someone starts on hormones, it makes their job a little bit more difficult because of the tissue that's already come in. So that's a whole interesting thing that and there's just no way to know that, or I would never tell a patient, no, don't start hormones. Let's just go straight to breast surgery. But I know that's been shared with me by some surgeons. While we're on surgery, do you think that phalloplasty surgery is sufficiently well developed for patients to get it now, or should they wait? Or do you think there are any good improvements on the horizon?
That's a really good question. I mean, there are more and more studies looking at, the patient-reported outcome measures and what it is that people want. I think you have to provide folks with all the options that are available now. So whether that's metoidioplasty, whether that's phalloplasty, I think that maybe the biggest changes are coming with the types of the implants that are being used. They have these are for people who've had phalloplasty so that they can basically have an erection. So there are new implants that have been developed in Europe specifically for trans populations. In the US, they're not available. So, people actually go overseas sometimes for these surgeries. So yeah, but that's expensive. So when are they coming here? When is the FDA going to approve these? I don't know when that's going to happen. So it's a good question, but
and when someone has follow-up, when they're surgeons overseas, if there are any kind of complications or things that need to be dealt with, that can be really tricky. I don't know how many times patients have showed up for you and say, can you take a look at my surgical site? And I say, no, I'm not a surgeon, but if I'm the next best thing, I'll do my best. That's hard.
I mean, the worst outcomes I've ever seen have been from people who've traveled even outside of state or outside of the country. And it's not because the surgery was poor. The surgeons are great surgeons, but you can't come home without the usual follow-up care and expect that everything is going to be all right. Complications always happen, especially with phalloplasty. So it is a problem if they're coming back and there's no urologist who can take care of it, and there's no gender surgeon around who can take care of it. And as a primary care provider, I can't fix this,
Yeah. And at least we're seeing, there's definitely more interest and desire for people to learn about, surgeons to learn about gender affirming surgeries. But I did read a a sad article in JAMA about the fact that there isn't enough capacity for them. So we're not, I mean, there are people who want this and we're starting to meet the need, but not nearly in the way we'd like to. So
Yeah.
There's one last question. I don't know if we want to end on the kidneys, because that's it's always an interesting way to end, but just sort of final thoughts on what the effect of hormones on GFR might be and how to deal with that.
Yeah, right. So, I mean, if there are quite a few interesting case reports that have shown, like, for example, there was a case report that looked at a transgender man who was denied PrEP. And the reason why he was denied PrEP is because when he started on testosterone and had, more muscle mass and the serum creatinine went up, they were using the female range, so sex assigned at birth, to estimate the GFR. So it looked like the EGFR was, under 60, and he wasn't able to get, oral PrEP with, FTC TDF. So this is the reason why I think you need to be aware that, after someone's been on hormones for 6 months, that you should be using their affirmed gender. Because if someone had looked at that using like the kind of male range, like the male numbers that estimated GFR, the GFR would have been in the in an appropriate range. So that was like an interesting case report that really highlighted some of the issues that providers encounter when they're using kind of like the wrong range or wrong sex marker. And also, a similar thing for trans feminine folk, when you'll see the GFR improve, right? Because, and we see this all the time, the estimated GFR looks better because now you have less muscle mass, the serum creatinine drops a little bit. I mean, it's not a huge amount, but all the studies really show that. So, instead of thinking, oh, look, for whatever care that you're providing, oh, look, their kidney function is so much better than it used to be, and now I'm going to make all these adjustments, right? You can't do that. You really should be using, again, affirmed gender if someone's been on the hormones for more than 6 months. Of course, we say that, but if you're ever worried, then just do a direct measurement, because there's some people who use small amounts of hormones, or people who stop and start their hormones. And especially if it was something like, I don't know, chemotherapy, where you really need to make sure that you're not making mistakes. I always suggest to people, this is critical, that you really know what someone's kidney function is. So they're going to have to do a 24-hour urine for you. So that's the answer to that question.
Yeah. Well, and then there's one last question. It's a pretty direct, specific question that I'm sure you can tackle fairly easily. I don't know if you can see it from Claudia.
Mm-hmm.
I can read it. What would you recommend as next steps for a transgender woman on IM estradiol who is consistently well above physiologic range, 2,000 to 3,000, and not taking prescribed dose? And she's declined PO or transdermal option.
Yeah. So, I mean, I would just say that the levels are high. You can also get trough levels just to see if they're really, really high. You can, we do this every 2 weeks, but, there's some women who only need an injection every 3 weeks. So you can have that discussion about, spreading it out, and yay, your hormones will last even longer. Yeah, I would do that. I think, 2,000 is way too high. When we're talking about, people, the upper limit of 200, and yes, if people are 300 or 400, it's not a big problem. But if someone's consistently got an estradiol level that is so high it can't be measured, or is in the thousands, an example, we had a client who was using, the 5 ml vials, that usually, so it's 1 ml every 2 weeks, just about. It was the 20 milligrams per ml, but was using the 5 ml every 5 days and had levels like that. But I do think some of it is because people are unhappy with the changes that they see. And again, like this is genetics, like taking so much estrogen isn't going to fix that. And facilitating a referral to a surgeon for breast implants, if that's what someone wants, may be the best way to deal with this.
Right. And then, I mean, then there's the question of liability, because I think, you know, in situations like this where you might say to a patient, I'm, you know, I can't or I have to limit what I'm prescribing because I think we're in a sort of a dangerous place. I think there's always the possibility still, right, that they can get them however they want another way. So, you know, how do you do that from a protecting yourself, protecting the patient, and also sort of our do no harm and harm reductionist approach, as a lot of us are?
Yeah, I mean, these are such great questions. Like we could have an entire day talking about it. You know, I think though that as more and more we're starting to see, you know, guidelines produced, for example, from the Endocrine Society and from, you know, the WPATH guidelines coming out next month. You know, these are guidelines that have, you know, are used by, you know, our colleague endocrinologists. I mean, like you can't practice too far out of established guidelines. I mean, there's always doing things a little bit, you know, you know, using things off label and so forth. And it's okay most of the time, again, to let levels go up a little bit, but it would be very hard to defend, you know, prescribing massive doses of hormones to a person. And sometimes it is the clinician who's overprescribing. I think that would be hard to justify, especially if someone had an untoward outcome event.
All right, that's what we have. A few people want your email, but I'm sure that will be addressed separately.
Yeah, I put it in the chat if you can share that.
Oh, yes. Missed the chat. There we go. Oh, I think it was just to me, though. Do you want me to? How do you want?
How we can, let me just see if I can do that. I can do it to everyone. Yeah, I'm going to put my email in. Keep an eye out for the new guidelines that are coming out. I think you'll be very pleased with the changes, especially with around access.
Yeah, that sounds great. And I know a lot of us are just really excited to see some changes that help our patients and perhaps help us as providers as well, making this easier. Thanks so much.
Oh, it's been a wonderful hour and a half. So
yeah,
thank you all for all of you who stayed on to this. Thank you so much. And I hope this helps your practice.
Thank you, Dr. Radix and Blumenthal, for the lively discussion. And of course, Dr. Radix, thank you again for the excellent presentation. As a reminder to our attendees, evaluations and how to claim continuing credits will be emailed by 5 p.m. Pacific time tomorrow. And this will enable us to review all of those that have participated and attended today's live broadcast. Here are a list of upcoming webinars that we have. If you are interested, next week we have a webinar with Dr. Jennifer J. Kaiser from the University of Colorado on optimizing antiviral outcomes through clinical pharmacology. Here are additional webinars that we have coming up and are available for sign up on our website. And here are 2 upcoming courses. Again, for additional information, please visit our website. Some other programs that we have include our COVID-19 dialogue series. Our next one will be on July 7th. And the Ryan White Clinical Conference registration is now open. Lastly, save the date for CROI, which will be held at Seattle, Washington from February 19th to the 22nd next year. This concludes today's webinar. Thank you, everyone.